For my Nursing 217 concept of critical care presentation, I wanted to focus on atrial fibrillation. The patient I decided to focus on for this project was a 69-year-old Caucasian female. She had an extensive cardiac medical history. Some of the disease processes she suffers from includes hypertension, hyperlipidemia, anemia, congestive heart failure, coronary artery disease, aortic regurgitation, and atrial fibrillation. She does have some congenital medical history regarding her cardiac health. These processes include patent ductus arteriosus and tetralogy of Fallot. Her surgical history reflects upon her cardiac history. She's had a mitral valve repair, a CABG, aortic valve replacement, and a Watchman placement. Her social history involves smoking. She did quit 3 years ago, but admits to smoking 1 pack per day. She denies any alcohol use. She states she does have an issue with frequent bleeding and easily bruising. She presented to the emergency department for palpitations, dyspnea, and hypotension. She told staff that she felt like she was having a flare-up of AFib, and these were common symptoms she felt with the disease. The EKG done in the emergency department showed that she was in tachycardia running in the 80s. The standard patient for atrial fibrillation often comes from European descent. This disease affects white people more than black people. For gender, it is pretty well distributed between both women and men. Some say it affects women more since they tend to live longer. Atrial fibrillation is more common in an older population. Some other risk factors include some comorbidities like high blood pressure, obesity, heart failure, hyperthyroidism, chronic kidney disease, or hypertrophy of the left chambers of the heart. Alcohol use and smoking can also increase the risk of AFib. It is a very common disease. 15 people in the United States will be hospitalized per 1,000 people. This does reflect an older population above 60. It was noted in 2019 that there was 183,311 death certificates relating to AFib. The CDC estimates that 12.1 million people will have AFib by 2030, so it is a very common disease. So what exactly is atrial fibrillation or AFib? It's an abnormal heart rhythm or an arrhythmia that results in the loss of atrial kick. What happens is the atria is quivering because the pacemaker cells cannot communicate properly. This leads to the blood pooling in the heart, which allows for clot formation. These clots can then cause a stroke or other issues in the body. As aforementioned, it is one of the most common arrhythmias that we see. One way to treat AFib or atrial fibrillation is through medicine. Medicine often has one of these 3 goals: rate control, rhythm control, or prevent embolism formation. Some drugs do rate and rhythm control. These include beta blockers, such as metoprolol or sotalol, or digoxin. Calcium channel blockers, like verapamil or diltiazem, are just used for rate control. Flecainide and amiodarone are often used for rhythm control. Amiodarone is an interesting drug. It is an antiarrhythmic that was prescribed to my patient at one point. However, it eventually led to hyperthyroidism. This is because it's 37% iodine by weight, which makes it very similar in structure to thyroid hormones. As the amiodarone is deiodinated in the body, the large amounts of iodine will cause damage to the thyroid. Some people also have decided amiodarone can be cytotoxic to the thyroid cells. This destruction can lead to hypo or hyperthyroidism. Besides rate and rhythm control, patients often have to take an anticoagulant to prevent embolism formation. Some of the common ones are low-dose aspirin, apixaban, or rivaroxaban. Those are used in the outpatient setting. In the inpatient hospital setting, a lot of patients are taking warfarin or heparin. Heparin is often given just prophylactically to prevent any clot formations as the patient is not moving. In addition to medicine, there are a lot of surgical and medical procedures that doctors can do to maintain AFib. The one I found interesting was the Watchman placement. Since my patient had a lot of issues with bruising and bleeding, she was not comfortable on anticoagulant therapy. Her doctors decided to do a Watchman placement, which is where a device is placed in the left atrial appendage. Blood tends to pool in this left atrial appendage, so by blocking it off, it reduces the surface area available for pooling, and therefore reduces the amount of clotting and decreases the chance of stroke. She still needed to be on anticoagulants during this time, but she was able to go very long without it thanks to this procedure. Another common procedure for patients with AFib is a cardioversion. It can either be done chemically with medications like amiodarone, dofetilide, or flecainide, or it can be done electrically, where shocks are given to regulate the heartbeat. It essentially resets the pacemaker and kind of allows it to recontrol the heart rate in the body. It's often done with a transesophageal echocardiogram, which is essentially an ultrasound for the heart. This makes sure there's no clots in the procedure. If a shock is given and a clot is present, it risks going to another part of the body. Finally, an ablation is another common procedure done for medical management of AFib. Here, small burns or freezes are done to chaotic heart cells. This causes scarring and makes them unfunctional. Next, I want to focus on what we as nurses can do to manage atrial fibrillation. When a patient with AFib comes up to our unit, it's imperative to make sure they have accurate lab work done. These include a complete blood count and a basic metabolic panel. This can rule out infection, electrolyte abnormalities, and make sure there's good thyroid function. In addition, the patient will need a chest CT scan and a 12-lead EKG. After those are completed, the patient should be placed on continuous telemetry monitoring to make sure that the rhythm is improving. During our assessment piece, we should make sure that regular vital signs are taken and we are evaluating neuro and peripheral vascular status. If there's any changes to hemodynamics, mental status, or circulation, the primary care provider should be notified immediately. Our goals for this patient is a normal heart rhythm and rate, as well as showing no symptoms of AFib, like dyspnea or palpitations. These patients often present acutely ill, but respond very quickly to our treatment. They will require a lot of education on the various procedures that might be given, as well as medications that they could be discharged on. AFib calls for a really united team. At the forefront is our pharmacist. These drugs require a lot of fine-tuning. The patient might be admitted and be placed on a heparin or diltiazem drip. The patient I'm using for this presentation was on both. These require frequent readjustments to make sure that they are doing the most therapeutic effect. They also need to ensure that there's no medication interactions, as a lot of these patients have what we could call a cardiac cocktail of different drugs. Cardiology will obviously be the primary team for these patients and need to be updated. Finally, OT and PT should be brought on. AFib can often make it difficult to carry out activities of daily living, so they might need lifestyle tweaks to maintain their best functional status. Shifting back to just my own patient and her time with atrial fibrillation. When she was up on our unit, her blood pressures were running a little bit soft, around 110/61. This is expected as she was on a diltiazem drip, which would keep her blood pressure a little bit lower. Her pulse ran between 60 and 70. She had normal respirations, but became a little bit fatigued when she was up walking around. She had great blood flow and palpable pulses. She was warm, dry, nothing showing a clot. She had no signs or any history of a stroke even, so her neuroassessment was consistently good. All of her labs fell within normal range, showing that it was not an electrolyte or a thyroid issue. When she did get to the emergency department, a troponin was taken, which was normal. This means she did not have a myocardial infarction. Her PT and INR were within normal range, which allowed us to give heparin safely. However, the heparin anti-X factor was consistently non-therapeutic, so the drip rate was constantly getting readjusted. My goal for this patient was to maintain safety. With the different medication drips going on, she had a lot of risks for injury. First, she should be placed on bleeding precautions. Since she stated she has issues with bleeding and bruising in the past, and the addition of the heparin drip, she was at a very high risk for bleeding. Here are some interventions that could help with this, including providing a soft toothbrush, ensuring supportive footwear is worn when she is moving, avoid straining when having bowel movements, and then monitor for any bruising. Nurses should be sure they're doing frequent skin checks, especially in places the patient cannot see herself. Another way to maintain safety is ensure there's strict fall precautions. Bed alarms are great for this, as well as ensuring the patient's wearing non-skid socks and understands that they need a nurse or patient care assistant with them when they're up moving around. For my patient, my safety goals were all met for my shift. Unfortunately, I left before able to seeing how the rest of her plan of care was carried out. I did see that she was scheduled for a transesophageal echocardiogram cardioversion. She has had these in the past, and they were all very successful at temporarily reverting her back to normal sinus rhythm and alleviating her symptoms of AFib. Hopefully this would allow her prognosis to be good and for her to be discharged home. While my patient did not have a history of strokes or have any signs of a stroke during her stay, strokes are a very common issue for patients with atrial fibrillation. Because of this, I decided to do my algorithm on a code stroke. So first off is always assess the patient. The acronym FAST is really great for this, and that stands for facial drooping, arm weakness, and speech difficulties. Time to call a code stroke. So if the patient is positive, go ahead and call the rapid response team. If they are negative for stroke symptoms, just keep the primary care physician informed, but continue to monitor. We'll jump back up to the top for positive. You want to make sure you note the time of symptom onset. You can delegate out a stat glucose and check their vital signs, and be sure to administer supplemental oxygen. Focusing on the vital signs, we want to look to see if their blood pressure is normal. However, if their blood pressure is high, you want to be sure to administer an antihypertensive. The symptom time onset is very important because it will let us know if we're able to give a thrombolytic like alteplase. Alteplase can only be administered if the symptom onset was less than 3 hours ago. It is much more effective the earlier you give the medication to the symptom onset time. So if yes, the symptom onset was less than 3 hours ago, be sure to make the dosage calculation based on the patient weight. If not, continue to monitor. For both options, be sure a CT scan is ordered, and be sure to keep the patient NPO until a swallow evaluation can be performed. And here are my references for this presentation. I hope you learned a little bit about atrial fibrillation.